we're meeting Zoom every Thursday morning. But he has a poster behind him, Ron. He's a pilot, owns at least interest in a small plane out at Poplar Grove Airport. But his poster is as if he were in a plane, a small plane, of course. And of course, he completes the image with earphones.
Ah, very good.
Good touch. Good touch.
And just a reminder, we are live. And the live is working.
Of course. And of course, he completes the image with.
And that was just a sound test of the live.
And Lucy, you look much better when we can see all of your head.
Well, can you hear me?
Oh, yeah.
Okay, because my son-in-law was up and I had him look at my computer to see why I couldn't get it on here. So he got that all set up for me.
May I say then, your camera angle is perfect.
Yes, you're getting the view of the outdoors.
Hey, Pat.
Hi, how's
Hi,
everything?
Pat.
Hi, Pat.
Hello, John.
Hello. Evening.
And Ellen. Hello, Ellen.
Greetings, greetings, greetings.
Hello, dog.
Big dog.
Oh, that's my dog barking. My husband's coming back up from fishing.
Hold on.
Just a reminder for everyone on the call, we are live streaming on YouTube.
All right. All right, let me see something. Who's here? Okay. All right, we're just waiting on Sandra. I think we have enough for a quorum.
Yeah, I just left her office. She should be on she should be.
I just think I saw a moving object. Yep. And there she is with matching jacket and mask.
All right.
Okay. Change my view. Excuse me, that is not COVID, that is postnasal drainage.
Uh-huh.
We have to send you home and quarantine you now.
I am quarantined. I'm all in my room by myself, but oh God, the allergies this season. Okay, so we'll go ahead and call the meeting to order. Do we have any guests or public participation? I'm assuming we could do that by Zoom.
Yes.
We can do that, but we do not have any guests today.
Excellent. We need approval of the agenda for August 18th, 2020.
So moved.
Second.
Okay. All in favor?
Aye.
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 Any opposed? Excellent. Approval of the minutes from July 21st.
So move.
Second.
Any discussion? All in favor?
Aye.
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 Any opposed? Excellent. We're having a presentation on COVID, the local perspective.
Yes, it's, believe it or not, it's another month. Well, this is actually a 2-month summary. I'm going to make sure I'm bringing up. It'll take me a second because I have to share my screen. All right. So I should say, is that up now at the,
Yes.
I can see it.
okay.
Good.
All right, there we go. So this is really a compilation of both, because we're August, we have June and July's data coming in together, but the goal was to provide you at least kind of an ongoing summary report as we moved through the pandemic. All right, so the current snapshot. And I want to make sure you did this slide change.
Yes.
Okay, thank you. Because again, I've got 3 screens up and I think I've got the right one on the current configuration. But you've noticed we changed our daily report to really provide a current snapshot as the state expanded its IDPH metric at the county level. And so you see what's called, we call it the 4 square, that kind of comes up every day to give individuals a kind of an understanding of what's been going on. And we highlight the case count, the positivity rate, the recovery rate, and the death count. We are color coding it to be consistent with the state of Illinois. Blue meaning you're in a stable zone. Orange means you're going into a hot zone kind of report. And so we started to put that out. And then what we currently have been doing is doing kind of a weekly summary as well then as our monthly report. So again, these are kind of the 4 metrics that we've been looking at to kind of report on a regular basis. In terms of testing, we come back to what's currently available. We've done as of, and this was as of July 31st, we did 3,626 tests, of which, and again, there were negative 47,000. And only included in this, I want to be clear as people kind of understand this more, are the diagnostic tests, which include both the molecular test, which the majority are, which is the RT-PCR, and the antigen tests. Now, we're not seeing antigen tests being heavily used, they're becoming more popular as time goes on. And then antibody tests are not reported in this, in these. So people are clear that those tests have not really been identified. And again, they detect the past exposure to the disease. We went over this, we talked a little bit about this last time, but we continue to put this R naught. Again, the idea being when R naught is greater than 1, the infection will be able to spread to the population. And so as we look at what data was going out there, there are multiple sites popping up now that will do calculations to do the R naught. One is the COVID Act Now, which is out of the Policy Lab out of Stanford, and another is out of Children's Hospital of Philadelphia. And so right now, both for kind of when you look at the numbers, our rate is calculated just slightly below 1. So again, as we start to look at metrics, as we begin to open up schools, why are we more confident? Is because our naught is less than 1. The other thing that we get a lot of requested information on is the lab turnaround time. So we do calculated just as we go through this overall turnaround time from specimen collection to test result. And we run these based on the data that we get from what's called the electronic lab reporting system is just under 2 days. The community-based testing sites like at the University of Illinois and College Health Sciences campus and the Crusader site that's at Auburn High School, they improved their turnaround time from just over 2 days to just under 2 days in July. Now, the private site turnaround time, so those are your hospital-based labs, physicians immediate care, actually increased from just under 1.69 to 2.73 days in July. Now, I've got to be clear with you that there's ongoing instability with turnaround times throughout the nation related to supplies, related to report through systems. And I think the other problem or question that our data people are looking at is the future. Understand how long does it take for results to be reported in through the INET system? So patients may actually get their results quicker in a private, provider setting. So for instance, if you go to Swedish American or Mercy Health before your surgical procedure and they run your test before a procedure, you typically have those results before we receive them through the INED system. And so understanding what that delay is, because to be honest, as a health department, the really meaningful resulting is when we get it in through this INED system at this time. So I think the other part is to kind of take a like testing by location is that about just 10% of our population has been tested. You currently, today I was on a call with Chicago was having their site team visit, and we were invited to participate. They're looking to be able to run a test and sufficient to test 5% of their population per day. That was kind of incredible to me. But most of our tests, when you look at what's been conducted, we're really about evenly split between those that are being conducted through community-based testing sites and those being run what we call private sites. So our Auburn testing site and our health sciences campus group and the pop-ups that were done through the state are really just running, kind of almost even with the private sector. I think cases and deaths, this is just a timeline understanding. It's a hard one to read, but as you would expect that, as cases continue to rise, so did the deaths. You start to see those as they, are initially when we had very few cases, we start to come in till we were, pretty much in the middle of May, and through July, we've had them to continue. Now, the rate of increase is slower than in May, and we're going to show you the doubling rate here in the next slide, kind of talks about, early in that pandemic when we had that rapid acceleration, we were at a 5-day doubling rate from about mid-April to just beginning of May, we were at an 8-day doubling rate. We now, when you start looking at progressing out, we're at over a 60-day doubling rate. So again, this really kind of shows that we're slowing. We're still continuing to have an increase in cases, but that doubling rate is not as rapid as it was during the rapid acceleration phase. This is our classic epidemiologic curve. It looks, beautiful like most curves look. What we don't see, and again, I'm sorry, does this show up? Is that what you're seeing in some other communities is this kind of seesaw. We are not at this point doing a lot of seesaw, but we're going to try and keep these strategies as we come out. Now, this is by date of onset. So that means that it's not the date of the test result, right, which can be affected by turnaround time and everything else. This is when we interview the individual and find out when did your symptoms first appear. If they were asymptomatic and just had a test, then it's the date of their test. But, I invite people to go and take a look at what other communities, what their curves look like. Ours has got a little more classic curve, and that's what we kind of like it to have in a pandemic, actually, because that means we'll trail out, we'll continue to cook with low rates of infection, and hopefully we don't go peaking up again. This just shows overall when we had our peak positivity rate, which was in April, which is kind of anticipated based on our modeling that we were using through Harvard and a couple other models that were looked at. And then we kind of continually declined. You hear a lot about this. Right now, we're reporting out a 7-day rolling average. So that's 3.8, but you can see our overall positivity rate is more in the 7% range. But this is what they're looking at when they talk about that returning of the metric or resurgence is when you get a 7-day average of greater than or equal to 8%. Cumulative positive to have been below 10% since mid-June, or 2 incubation periods. And with increased testing, despite the fact that we have more positive tests, positivity. And again, we kind of reflect back, almost 18% of the population was tested as of July 31st. This is another interesting, this is the overall distribution of cases and deaths remain consistent among age groups. So what you see is a spike in the 20 to 29-year-olds, and you see no deaths in that group. And then the highest death rate is up in the 80+ year. You start seeing it begin was the recommendation and the concern initially when we heard about 60 and older, and that has been, it has continued throughout. What we're going to be watching for as we start to return to in-person education, obviously, are we going to get an acceleration in the 10 to 19-year-olds, right? And as well as the 0, certainly in the school age, so the preschool 2 to 9. And when you look at this, you think 14% were aged, 0 to 19, 21%, 20 to 29, 43, 30 to 59. So when you start this middle grouping is when you start seeing the greatest amount of infection is out there. And we've talked about this before, why is that this group that's out more? We've seen a lot of studies that are looking at their social behaviors. I just got I'm sure a blurb, some of you did, we saw 2 college campuses that started in person have returned to remote based on the number of infections, one of them being Notre Dame, just announced that they're having to go back into. So again, this group is practicing tightly, but this group is having a little more difficulty in maintaining social distancing and keeping their infection rates down. We have not seen significant changes over our pandemic. We've remained fairly consistent with overrepresentation of our Hispanic and Black African American populations in infection rates. And both of them have 2 times, they're more than 2 times as likely to be infected with COVID-19. And this one is kind of cases by race and ethnicity. If you were to take a look, and this is in your packet so you can blow it up a little bit more, it'll be on the website so you can pull it out, is when you start looking at the overrepresentation in the younger ages, especially for our Hispanic, Latino, and our African American populations. And this is what we'd expect, what they are represented normally in the population. And this is where they're at in terms of the bar graph, in terms of race and ethnicity. So again, overrepresentation in the younger age groups. And then again, the age-adjusted case rates. This is, as in public health, we do that to provide further insight to understand those disparities. And so what you start to look at, when you start looking at where they're at in terms of overall and age-adjusted rates, you have a significant increase in both the Black, not Hispanic, Latino, and then Hispanic Latino population. So and again, we see even a larger disparity among our Latino population. Now, I also come up with distribution of cases by age and gender. We had noticed earlier, this is it's not a propensity for a genetic component, but women tend to be more impacted disproportionately by COVID-19 as well. And especially as we get into this younger grouping, females are more likely to be impacted than males. And there's, again, some of the discussion items for our essential workforce. It might be, when you take a look at what they are in number 1 occupation, I'll let you guess again what that is. And is there an overrepresentation of that gender and age range in that sector? One of the things that we've been looking at as well is, we modeled hospitalization, and hospital capacity has been part of the discussion all along in this pandemic. We're pretty holding steady in this, that more than 2/3 of our cases have not been hospitalized. But among the hospitalized hospitalized, you have almost a 40% chance of being admitted to an ICU, and 14% will require ventilator support. So this idea that, you know, we don't use ventilators at all, it's under the 20%. So some of the projections we initially had, hospital admissions, 80% requiring hospitalization, we certainly are below that. So that's really the positive side, is that the severity or number of cases requiring hospitalization and mechanical ventilation really did not, you know, that some of that modeling was not, we had, I'm going to say, better outcomes than China did in its initial, which is where some of this data initially, how did we model some of this forward? But I also want to come back to, if you end up in a hospital, you know, length of stay, almost, you know, 3/4 had a length of stay of 10 days or less, and 10% had a length of stay of 21 days or more. So there seems to be a kind of a big gap between, if you're, you know, if you're lucky and you do pretty well, you're out pretty quickly. The other remaining, you are going to be in there for a significant length of time, almost 3 weeks. And I think that is a concern when you start thinking about that. So you can see the majority not hospitalized, and then not in ICU. ICU is 4%. And then this is where we have individuals where we are still getting their interview, getting their records in, if they're not sure what section of the hospital they were in. Sometimes we'll get the case report after that. Our communities of concern, which we have termed our high-risk zip codes, continue to, the top 5 continued to stay pretty stable, but then I flipped, you know, positions 1 or 2, or 2 and 3 in this case. But the same 5 top zip codes remained, and those were all really, when you look at 61104, which is Rockford, 61108, which is Rockford and portion of Cherry Valley, 61101, Rockford, 61102, Rockford, and 61103, Rockford, McChesney Park. And again, tied to really population density kinds of concerns. We've not done a deeper dive on that, but we certainly are going to start doing some overlay as we go further into that. It continues. Because, and this is seeing nationwide about some of the numbers coming out of like New York and Chicago, where the population density, what is it per square? Now, but you notice there's really, there's only one zip code that seems to be coming out with less than 5 cases. So when people say it's nowhere else, yeah, it's, you know, yeah, it's throughout our county. This also took a look in the same kind of discussion that we had. We looked at what about some of those zip codes in some of those areas. And we knew that there was, in our racial ethnic data, it's higher in communities of color and higher in communities with lower socioeconomic status. Congregate settings have continued to plague us and throughout the nation. Now, Chicago reported on some data. Theirs was starting to kind of ramp down a little bit. Ours was a little bit later in the ramp up, and so we're a little later really getting most of the infections under control. But I often hear about, you know, the kind of the, I'm going to call it the game of, well, is it the patients or is it the staff? The staff are bringing the patients, you know, this kind of showed that infections impacted both residents and staff. If you look at blue as the residents, employees, there's in a skilled nursing, there was a 1-to-2 ratio between staff and residents. Senior living, a 1-to-3 ratio, almost equal in group home between staff. And that may be, again, understanding a little bit more, some of the staff may actually live in the group home with the individuals, kind of a different scenario. And really the only other time where we saw was people that were for rehab treatment, homeless shelters, staff were greater impact, slightly greater impact than residents. And this is a breakdown of race and ethnicity by congregate setting. And again, for both employees and residents, you see in healthcare, again, an overrepresentation of the Black African American and Latino. And then again, when you get to residents, though, you see an overrepresentation of Caucasian. And again, we've talked about the privilege of living longer. And this is your healthcare worker group. So when you think about when we're going to look at the data, you could probably tell me which occupations more likely to be associated with an infection. And of course, mortality was associated with locations of concern. 64% of deaths in Winnebago County were associated with a location of concern or a congregate living setting. And that's higher than the state, which is currently indicates that over 50% of Illinois deaths have been associated with long-term care. So we'll continue to monitor that situation, and we continue to see our increased number of deaths was pushed just into the orange block was related to a long-term care facility deaths. I don't know how well this one plays out. So morbidity, long-term care facilities, was the majority, again, when you did COVID confirmed cases associated with long-term care among Winnebago County. When you think about morbidity versus mortality, there was a higher mortality rate associated with long-term care facilities. So again, when you start thinking about morbidity, it was more likely to be associated, I think you've got this mislabeled, with a long-term care facility. So we'll go through that because again, higher rates, we knew that from the get-go, were associated with our long-term care facilities. I said this as a joke last time. The number one occupation was none, retired, not working, but I don't think retirement is a cause in and of itself of death from COVID-19. But again, this reflects your skilled care facilities and some of your congregate facilities. So because they've lumped both retired and not working, and these are fields within INED, so we cannot break them out much, more than that at this particular time. Now we're hoping Salesforce may give us more granular data. But 10% were associated with healthcare and direct care. And another, when you look at healthcare worker other, that accounts for almost 12% of infections were related. And then you get a smattering between factory workers and then food service, retail, office. But again, healthcare worker became the number one occupation and continued through the month of June and July. So our top 10 comorbidities did not switch out during this time frame. They're the same, they've kind of persisted. And I put this graphic in here, and I think it's really helpful to understand. Our number one in rank order was hypertension. Second was diabetes. Third was unknown, asthma, current smoker. Obesity came in at number 6. And when you look at some of we're a little bit different than how the national data, where obesity, a BMI greater than 30 had 3 times the risk. So when you look at rank ordering, we're probably a little off on that. Diabetes followed, was kind of similar in that regard. But we're pretty close on the top 4 and top 5. And I think the scary part is as 3 or more conditions came up, you have 5 times the risk of mortality associated with COVID-19. And again, it's the hospitalization. You have 5 times the risk with 3 or more conditions. And when you start talking about individuals, you get the trifecta of, diabetes, hypertension, and obesity, and age, you then become in that higher risk for mortality. So, the best picture is, we really have to kind of always be pulling this because they went through a phase where we only reviewed deaths associated with death certificates. And so we actually have death certificates pulled on a regular basis. And we looked at that 86% of our deaths had COVID-19 as a final cause of death. And you can see 16% had COVID alone, 22% had COVID-19 in some form of pneumonia, and 16% had respiratory failure, acute failure syndrome kind of co-associated with it. And then we have the other 14% where it was a contributing cause. And again, it's kind of difficult. We have to pull that out as a contributing cause. It's usually item line number 2 on the death certificate. 57% had no additional contributing conditions. but 43% had another comorbidity associated with that. And again, you see it coming out here in the congestive heart failure, the COPD, hypertension, and myocardial. And we continue to work through that. Our coroner has committed to getting a specimen right now on any death, partly because people that die at home, we're not sure, and understanding if there's a comorbidity associated with it. Some people will say they had a respiratory condition, if there was an unattended death, as well as the attended deaths in the hospitals and skilled facilities in which there's COVID. So why did, I mean, I know Pat reached out to us at one point as a board member and said, tell me what's going on and why you aren't putting out as many. Well, I'll be honest, the state put out a new metric board almost every day for us. And so we want to be kind of staying up to date. The county put out the most current one, is called the COVID-19 risk methods. And it looks at the 8 restore, which is new cases, 200,000, number of deaths, test positivity, test perform. This is where total test perform they can pull that I can't get at a local health department, because they're able to pull from all those sources versus the positive reports. Emergency department visits for COVID-like illness, hospital admissions, clusters of cases, and ICU bed availability. So you can drill down to the county level at that data for that. And that's how we end up in what's called, we're going to go into the orange zone. You'll see one of these come up with a warning. You'll come through. So at this point, when we first pulled it, the whole state was in the blue. If you look at that state report today you'll see a lot of orange down in here. There's orange coming up in here and some orange down in central Illinois. And then they started another tracking area related to our resurgence criteria with our region, which we are in region 1, which matches up to what we call our EMS region, our emergency medical services. And so that was introduced on July 14th. Winnebago County is region 1. And what you can do is they'll take a look at the various metrics related to that. So they are looking at that 5 days of positivity. They're looking at different kinds of 3-day rolling averages, hospital availability. And these are the metrics that say if we have to, the question was, when do we have to, if we have a resurgence in cases, what are the next steps that would be taken? And there's a tiered approach. We would not revert back to a phase 3. We'd implement tiers of social mitigation strategies that might be closing bars and restaurants, reducing capacity. It might be closure of certain types of business or industries if there was associated cases with them. But again, this is constantly evolving, and we heard that they now have a new report that's coming up to support the return to school metrics. So now you will have all kinds of county level data to drill down to. But our goal was to kind of put out a monthly, to my bi-monthly report to give an overview of what we're seeing on our data that these data sites don't provide, such as the race and ethnicity, the occupation, the hospitalization. They're obviously zip codes or communities of concern and our locations of concern. So our data team, just to give them a shout out, Abby Hitler is one of our MPH student interns, Angel Abraham, who's our epidemiologist, and Peter LePayton, who is our data and quality. And he is at training today they restated the, just so you know, the training for emergency management, and they are taking their incident command level while they're living it, of course, at one of the higher levels, both he and Jim Keeler. I think Jim's on tonight anyway, but so they are there. So they've been working a lot. Every day they help to put out some of this data and those reports that we post and that we do on the summary. So that's our local perspective in a nutshell. Anything stand out? Any questions that you wanted to ask? Anything that you thought that, if you'd like to see if we can try and get at it?
Very informative.
Thank you, Sandra. That really answers the stuff I was getting asked, and I have been getting questions. So that is really helpful.
And we hope to get it. And again, I wait till all you see it before we can post it, so that you've had the first opportunity and glance. But our goal was to put something out monthly, to bi-monthly. I mean, we got away. June ran away from us, so we now have July and August combined, so we can put that up. But again, it could put that local perspective together. So that people can see what's going on. And I know I saw today, I'll be honest, I saw some of the firepower that Chicago had. They actually can get you the raw data if you want to pull it down from there and from their SQL servers. That's not something we can provide at this time.
I don't think my questioners were asking that. They were pretty simple. What's really happening here? How long will it take me to get a test back? What's really going on right now? That was what I was getting.
All right. So we will continue to put this out, and we've also returned because people really liked what we used to call our daily report. Kind of did a date, and when the state started putting out their daily report, we really didn't want to get people all confused. So we're doing now ours as a weekly summary. So they will post that. So we will put kind of a look back and view, and that will give us like the race and ethnicity, the epi curve, some of the other data, communities of concern and locations of concern. People were very interested in where outbreaks were occurring and when they were coming off and when we're going to put them back on. So. All right.
Excellent. Thank you.
All right.
Here we go.
Back up.
All right. I don't see anything for the president's report. My eyes are missing it. Winnebago County Health Department updates.
Well, and I will defer. The major update I want to share is Todd Kisner's on, can talk about his new contact tracing team that started.
Yeah, so we're excited. We have 11 individuals started Monday as part of our contact tracing response team. So we're really excited. They're all here and learning and eager to start. So we're excited, and I know from the perspective of the team that's been working on this for some relief and help in that. So excited bunch of individuals. And so we're looking forward to get them up and hopefully by the end of the week through all the training and be live working with people next week.
Excellent.
So we have 11 of the 31.
11 of the 51.
Okay, I wasn't sure if you were talking about just the contact tracers.
So these are, of the 11, there are 2 supervisor positions that are in there, and then the case investigators. So the case investigators, Dr. Helvelson, are the ones that'll be interviewing the persons directly. Contact tracers will be the ones that once we identify individuals outside of a household that need to be out and provided guidance, that's the contact tracers. So they'll be in the next group. Our concern right now is to getting additional staff on board to be able to reach out to talk with individuals directly and then help us guide us if there's businesses involved, schools involved, long-term facilities.
Todd, do you have is there a timeline in which we hope to have the entire group hired by?
Yeah, so in the meantime, while we're training, they're renovating the 3rd floor right above us.
Great.
And I actually stopped by and stuck my nose in between the doors. Beautiful paint job and some beautiful carpet down. And so hopefully, haven't seen an exact time frame when the new furniture and stuff will arrive. But our hope is to get this crew, current team of folks up and running and hopefully moved upstairs and bring the next group. Then we figure on a more 2-week cycle bringing them in. So if we can accommodate 11 in the training room, as I call it right now, because of COVID the 6 feet, apart from everybody. So we can do them in shifts in 10. So I would say hopefully by mid-October, everybody would be on board.
Great, thank you.
Sure.
I have a question, Todd. So we're looking to hire several more people. Have there been enough applications? It does seem like people are coming in for these positions.
Yeah. So HR was there today to talk to the group and fill out all the stuff that they have to do for HR. And Maggie, who's been kind of leading the charge for us, said there were another 38 applications in addition to the first group that we had. So HR is going to vet these new applications. We have some of the other positions, the coordinators and stuff that we've gotten. And so now we're moving to hire them into the next round. So I think we have plenty of applications, but we're still posted for the next 30 days out there. So if you've got folks, still have them apply. We would appreciate that and continue interviewing as they come in.
Okay, thanks.
You're welcome.
And probably the other biggest area that we're working on, which pretty much the whole team is working on, which is why I'm anxious to get Todd up and running. And it's taken a little pressure off Todd Marshall, just briefly, is getting ready to return to some in-person education. We've been working diligently over the last 6 weeks, but very intensively over the last couple of weeks. School nurses, school districts, school boards, local, regional, and superintendents, as you would guess, to bring us through all the guidance regarding schools. We are the largest district in the state that's going to attempt to move toward in-person, offering that option. Our infection rates allow us to do that. I want to be clear with individuals that our current rates and our current positivity and availability of testing, as well really is the commitment to the schools to be able to offer that. And it was interesting, some have about 80% enrollment in person, to Rockford Public Schools reporting about a 50% in person versus remote. Some of our schools started this week and we're coming across some hiccups, and we'll continue to monitor through that. But that's why the contact tracing team is critical to have on board, because there's going to be a dedicated team to that, as you would guess, understanding how kids flow through school. Every time we think we've understood every way that children receive education, we find there's one kid that comes over from some other county for this class, and figuring out how do we do that in a way that's safer, as safe as we can possibly be, understanding that we are not going to go zero risk, but we are going to reduce that risk and keep that strategy as going. So the Joint Information Center has been working a lot on messaging for parents. We are looking at the contact tracing team as they prepare for it. The only thing they haven't complained yet, Todd, is about masking. That will be next, I'm sure. It's a requirement. And the state has also been working through some of this guidance. It's extremely, as you would guess, a very tentative time as families want to return. Our travel guidance, for those of you who are interested, Hawaii was added, but Wisconsin was removed. So now is the time to book your plan to Wisconsin, but not Hawaii.
Okay. I have a question about the schools. So are they gonna do? I'm not sure if they're taking temperatures. They'll require the kids to wear masks. I'm sure a brochure or handout email or something went to the parents that if your child has a cough or fever, whatever, to keep them at home. Because the only reason I bring it up, I think it was Indianapolis or somewhere in Indiana, child had symptoms and tested for COVID, and the parents still sent them to school, and then the child came back positive.
Yeah. We've already had that scenario in the camp. They don't quite get the concept that when you're testing, even though they provide educational materials, that if you're testing, you need to stay home and quarantine. And so, Dr. Williams, to your point, Yes, there will be screening. There will be self-certification. Most schools have some application or app that they're using, either, computer-wise or telephone, that you have to basically self-certify that your child is coming to school without an infection. In addition, and temping inside the classrooms or their cohorts. It depends upon where the entrances are. Each school is a little bit different.
I lost my picture.
But, and of course, everyone will do a great job. And then the parents will have to. Who's got a funny dog?
Oh, I gotta put this on mute.
But
Must be a raccoon.
yeah, I know. We saw something, a squirrel running by. But I think that the challenge will be then in the off hours, right? Are parents cohorting their children enough? Are they keeping their contacts and limits as low as they can go? And, again, everyone's got to try and do their part. We're hoping that we can reduce the number of times that in-person education has to go remote. The state is calling it adaptive learning, so that we don't have to go through a lot of adaptive learning. But I really want to be clear in the terminology. Yeah, I don't want to have to, if you're going remote like this, in and out, but you don't want to have a sudden all remote where you've not been able to make contact or establish a child's learning pattern. And as you would guess, all those new school nurses need to be N95. They're being fit tested right now. They're learning, all the PPE for the medically fragile children who, in terms of in-person education. So the suctioning and all of that goes on in a school environment that for families that need
That's right.
respite care, I'm going to say in some regards, as well as the academic enrollment and academic, educational instruction. So it's going to be, I'm going to say, a very rough month for both looking at our metrics, understanding patient, parents and families and their anxiety levels, and concerns about have they made the right choices as they move forward, and then supporting families in that choice. I think it's admirable that our schools offered the choice, and then they're working to carry through the choice. So we will continue to work with them every day. There's 2 or 3 school meetings related to that. But it's been kind of fascinating to see all the air exchangers, and Todd and I are going to see the ultrasonic cleaning that they're putting up, the electrostatic chargers that they're putting in one of our schools, and the thoughtfulness that they've really, again, in attempting to bring people back online. And Dr. Williams, we are going to need physician help on this one. We need physicians to help us document medical conditions, because the state is going to be very tight on when a child displays any symptom, that they are evaluated for another condition and that they're tested before we bring them back into the classroom. So I know that that's going to put a lot of pressure and strain on our healthcare. So that's the next group I'm reaching out to, as well as guidance came out today to physicians about how to assess children for the capacity and really capability to wear a mask. Because if you can't wear a cloth face covering or a mask or a face shield, the environment of the school will be much more risky for that student. And, the teachers will all go into a higher level of PPE at that point, but you can't move that child into a higher level. And so that will create some undue pressure.
That's interesting, because I know that, Southwest, there was a little 3-year-old autistic child who refused to wear a mask, and they kicked him and his mother and younger sister off because Southwest says no matter what, if you can't wear a mask, you can't come. So my one question I was worried about was the kindergarten age, first grade kids. Will they keep their mask on all day? The pre-K kindergarten.
They've thought of all kinds of things, everything from like little mitten clips, right? So to keep it on them, because they don't want any lanyards on them, per se. the teachers know they're up for a struggle, but they're also cohorted very tight in the smaller grade, the younger pre-K, early childhood. I'm probably not using all the right terms that they would use, and the earlier childhood. Yeah, the class sizes are typically under 20 now for Rockford Public schools, and the pre-Ks and some of them are down to like a cohort of 8 to 10. So they're really working hard to get those numbers.
And the rules apply to public and private?
Yes, they do. In Illinois, they do.
Okay, because I saw an increase in the number of students going to private school was reported, and I just wanted to make sure that the rules are going to be the same.
They are, and they are also struggling as well about the same, and I'm going to say the same issues. And the nice thing I'm going to say the positive has been pulling those groups together. Both the private and public superintendents and principals have been together on calls and standing firm on how that should look. Because again, they don't want to, they both have, I'm going to say they both have a commitment to understanding the community, providing education, and not in any way, shape, or form. Again, if you get individuals who refuse to mask, it places your whole population at risk.
Right. Okay.
Anyone else want to provide an update outside of COVID? I guess something interesting outside of COVID, maybe, huh?
Yeah.
Cheryl, how's electronic benefits going for WIC?
So I'm free to go back and forth to Wisconsin now?
Yes, you are.
Good.
You can come home, Lucy, and then
We have to go. We're coming home Sunday for a couple of days because Tom's got a doctor's appointment, and then we're coming back up.
Committee report. Nothing, it seems, from executive committee. And I know I saw her bright face. Jamie's on for finance.
You got
Here's Jamie.
That's right. Okay. So first of all, we have the approval of minutes for from the Wednesday, August 12th meeting.
Move approval.
Second.
Any discussion or corrections? All in favor?
Aye.
Any opposed? Okay, minutes are taken care of. Now we're on to page 42, the resolution of expenditures for the month of July. Expenditures incurred were $1,110,008.05.
Move approval of the expenditures.
Second.
Any questions or discussion? All in favor?
Aye.
Any opposed? Okay. Next, we have page 43, which is the statement of fund balance. For month ending 7/31/2020, we had a net increase of $476,857.80. Anybody have any questions on this? Okay. Page 44. This is the 10th month of the Winnebago County fiscal year 2020, and it is the first month of the state of Illinois fiscal year 20. Isn't it 2021? Okay. Year-to-date revenues budgeted was $10,288,898.33. The actual was $8,114,926.64, with a variance of $2,173,972. Expenses were budgeted at $10,293,473.33. The actual and encumbered expenses were $7,638,068.84, with a variance of $2,655,404. Questions, comments, or concerns on this? Okay. Go to page 45, which is the balance sheet. Jim, anything that you want to point out here?
Just that we have, our receipt of our 25% deposit on the contact tracing grant, which is deferred revenue of $1,064,000. So we have received a deposit and have been working those funds.
Great. Anybody have any questions? Okay. Page 46 and on are the bank reconciliations. Does anybody have any questions, comments, or concerns on those? Okay. Then that gets us to page 59. Revenue and expenditure report. If you go to page 61, you can see that there were quite a few transactions that were posted after our board meeting in June. Jim, anything that needs to be pointed out? Anything?
Well, the month of July, we had, quite a bit of expenses with the way the county set up. We had 30 days of payroll, but we also had, quite a bit of revenue and a lot of bit of expense reimbursements coming for items that we spent towards that contact tracing. So the numbers were rather, larger, over $1 million for $1,031,000 in revenue and $1,110,000 in expenses. So we had a slight deficit this month, but I think we're doing all right because we did have 3 payrolls this month, and we have our quarterly allocation coming towards the end of September for the property taxes. So we're doing fairly well at this point.
Okay. Does anybody have any questions? Okay. Then we're on to page 63, the public health emergency reserve minimum. We are just over 8 million, which is just above where we were last year at this time.
And that excludes the $1,064,000 that we received, because if we owe performance on there, it's not really cash reserve. So
right.
I set the formula up that way.
That's perfect.
Good.
Okay, does anybody have any questions? All right, on to page 64. Major expenditures. Let's see.
I believe we covered everything in committee probably, but the very last one.
Right, items A through G.
Yep. So items A through G were approved in committee. Does anybody have any questions on those? Okay. Is there a
Did you need a
motion?
You need a motion.
Yep.
Yep, recommend we accept the expenditures as proposed by committee.
Okay, all in favor?
Aye.
Aye.
Any opposed? Okay, expenditures A through G are passed. That brings us to H. For environmental health, it's for Gallagher Bassett Services Incorporated. It's the environmental consulting services at 401 Division Street. The actual amount is $6,150.
So moved.
I'd like to make a correction to that. It's under the Center of Health Administration, not Environmental Health.
Thank you.
My motion stands.
Okay. So we had a motion. Did we get a second?
Second.
Okay, any discussion?
What do we have here?
If you may, I can, with Gallagher and Bassett, actually to sell a building or demo a commercial building, we need to go through a phase 1 process. And Gallagher and Bassett obviously provides that service. The county has used them historically through in this type of process. Basically, a phase 1, there's 3 tasks. In your packet, you'll see the 3 tasks that we're getting charged. The phase 1 ESA, basically it's a lot of research, any historical spills, any underground tanks, any leakage on those. This is the general information on that. The limited asbestos screening is really checking out the deal breaker. What I mean by that, that's why we're doing limited. The deal breakers, they're going to be doing some probes in there. Basically sheetrock, material that's roofing material, things like that. We need to identify that. Most people that buy buildings like that, they're not concerned about the wrapping around the pipes or tile or anything like that. They're intact and all that, but they're really concerned about sheetrock and roofing material. So that's what we're going to go with, because obviously that can be a deal breaker if we decide to sell it. And the last one is lead screening. They are going to take a few paint chips. That's a minor cost that actually is being analyzed at a certified lab. That's
okay. All in favor?
Aye.
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 Any opposed? Okay. All the major expenditures are taken care of. Next, we are going to propose contracts and agreements on page 112.
Which we also handled in committee, correct, Jamie?
You did.
What?
We handled those in committee and just
Yes,
need approval. Unless
we do. We just we need a motion to accept them on the committee.
So moved.
Second.
Any discussion? All in favor?
Aye.
Aye.
Any opposed? Okay. Then the contracts and agreements are passed. That gets us to page 122. Okay. And this is our fiscal year 2021 budget. And it was approved out of committee to come forward so that we can recommend it to the full county board.
I would move that.
Second.
Is there any discussion? All in favor?
Aye.
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 Any opposed? Okay. Do we have to do each one separately, correct?
Yes.
Yeah.
Okay. So that was for
The health fund.
the health fund. Now we're going to do 555, the building fund, which is on page 162. Okay, and this again came out of committee for recommendation to present to the full county board.
I would
So we
move
need
that.
Okay. Is there a second?
Second.
Any discussion? All in favor?
Aye.
Aye.
Aye. And any opposed? Okay. The budget for 555 passes. And that would draw a conclusion to your financial portion of today's event.
Excellent.
You did a great job.
Policy committee.
Policy, we need, let's see,
Coming from Stonehenge.
Yes, where all the original policy was. I need a approval of our minutes from August 12th.
So moved.
I'll second.
Any comments, corrections? All right, all those in favor?
Aye.
Aye.
Opposed? The board handled two things. I mean, the committee handled two things, recommending to the board approval of the resolution to encourage the use of face masks, coverings for the prevention of the transmission of the virus. That's the first item that you have. It doesn't put any teeth in it. It's just a recommendation of an encouragement to the community to do this. And do I have a motion to approve that resolution?
So moved.
Second.
Any discussion on it? Skip the whereases, go to the therefore, and you'll see what it's about. All right, all those in favor?
Aye.
Aye.
Opposed?
Aye.
And the second piece of business is a memorandum of understanding between the health department and the city of Rockford. There are 3 of the communities in our area that are enforcing face masks and other protocols for the virus, and it's, well, 4: South Beloit, Cherry Valley, Loves Park, and Rockford. And this is the first of a memorandum of understanding with one of those municipalities to forward information about any violations, but still retaining the health department's rights to close down anybody that's continuing to violate, and retaining our rights to all the procedures we want to take. Do I have a motion to put it on the floor?
So moved.
Is there a second?
Second.
All right, discussion.
That's not all of Winnebago County.
I'm sorry?
You said Loves Park, Cherry Valley, Rockford,
no,
and what other?
I didn't say it was all of Winnebago County. I said there's only
Right. My question is, what happened to the other municipalities? They chose not to participate or agree to the memorandum?
Well, this memorandum only handles the city of Rockford, this memorandum of understanding. As far as enforcement, Sandra, I don't know why the other ones, maybe they're working on it now.
Well, first of all, City of Rockford is the first one we approached to go through, because they had already done some enforcement activities. We then learned policy that City of Loves Park, South Beloit, and Cherry Valley had also enacted similar type ordinances. So the next step would be to reach out. We talked to them about the concept of this. We had a little trouble tracking down their actual ordinances. Charlotte and I have been trying to work through that with the policy, the same for any municipality. And it really,
Sandra, we're losing you as far as your sound.
Okay.
There you go.
Pat, I think you need to mute. Thank you.
Okay. It has to do with the fact that it's the delegation really of the enforcement activity is really related to the health department under the executive order. And so as the municipality puts an ordinance in to do some of that work, we wanted to be able to send to them complaints that we were receiving so they could enforce it under their ordinance and allow us to continue. For the areas that are not covered under a local municipal ordinance, we are still responsible for those enforcement activities and would continue to carry them out as we do now.
Okay.
really provides for that transfer of information back and forth between that for the purposes of the enforcement of their local ordinance.
Okay, all right.
Did I do that correctly, Charlotte? Okay.
All right, thank you.
Okay, so we have a motion on the floor for approval of the memorandum of understanding between the county health department and the city of Rockford for enforcement of all the protocols for the virus. All those in favor?
Aye.
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 Opposed? Opposed? All right, that passes. That is the conclusion of the policy.
Excellent, excellent. No meeting for personnel or quality. Do we have any new business or correspondence?
Mr. President, just wanted to do a little ahead of time advanced thinking and check with Dr. Martell about how we might be handling flu shots for the board this year.
It's by Zoom, Jim.
I should have known. I should have known. So anyway, I just wanted to check with Dr. Martell about that. A little advanced thinking.
And we have both Cheryl and Mindy are on the call. They are kind of our leads on our flu. And of course, we will make arrangements for our Board of Health to receive their annual flu shot payment. I know that it is one of the perks of being on the Board of Health is to receive your
Got to get these perks where you can.
No, and we will have to make arrangements to be able to provide it in a socially distanced and COVID appropriate manner. So we will work through those details as we go through the process. But at this time, have we received our vaccine in-house yet, Mindy?
No, it has not come in yet. I'm expecting it very soon, though.
So does that mean they throw the syringe at you from 6 feet?
I'm sorry, I didn't catch that.
Sandra's giving me a what for right now, but she's got her microphone muted.
Oh, here we go. We could do a curbside pickup for you.
A curbside pickup, awesome.
Is there,
I also have gotten questions about flu shots. You must all hate my people who call me up, but the question is, how should they strategize when to get their shot, hoping to be safe? You know, we're in the older age generation, hoping to stay safe long enough.
We're probably going to encourage everyone to get the shot as soon as it's available so that we can mitigate the flu season. Also, you want to spread it out because hopefully, December, January, sometime February, the actual COVID vaccines will be ready. And it's going to be ramped up, I'm sure, everywhere nationwide to vaccinate as many people who want to be vaccinated and need to be vaccinated.
Agreed.
I wonder then if the health department ought to have a message on the website or something to help people make some of these decisions.
We can certainly have that out for the Joint Information Center to put out because we are starting. We've been focused on back to school immunizations, getting those up to speed. The next one would be flu, and Dr. Williams is really, we're going to be pushing it out as soon as you can get it. If you're also due for those individuals who are novice to the pneumonia shots, getting those as well, because as you could see from the data, there was a high rate of comorbidity with pneumonia as a contributing cause to mortality. So I think that's the other part is to get that as soon, because it is hopeful and ever optimistic that we've been told to anticipate that we will have some vaccine against COVID by the end of the year, beginning of the new year. So again, we're going to try and get populations. It'll also give us a chance, and all kidding aside about the 6 feet and everything else, we are going to try a bunch of different strategies. The contract that we went through finance was that advanced planning. The typical pandemic flu vaccination response did not have a lot of the mitigating factors on it that we've done in the past. So it's going to be smaller groups. getting it out more to individuals or what we call closed points of dispensing. So this is a perfect example of a closed point of dispensing at a health department or board of health. And also, I mean, all kidding aside, we may ask you to drive through just so we can get some throughputs of what it's like to do a drive through and get your vaccination. Because again, we're not going to be able to put people in a big center and have them stand and wait in line for a vaccine where we have a very, very high rate of transmission of the COVID. So, and again, get it as soon as you've got it in your areas. I have not seen it though arriving yet in some of our retail pharmacy. Usually they're the first to get it. It's not been,
They do have it.
What?
Walgreens has it.
They already have it? Wow. Okay. Because I hadn't seen it on their website. So we're encouraging early vaccination along with make sure that if you need to submit your mail-in ballots, that you take care of that as well. All this early, better to plan early and ahead. Get your gifts for the holidays ordered online early because again, postal service may be impacted. Do all of that. Early is better.
Agreed.
My husband has been getting his Coumadin checks on the drive-through.
Excellent. Any other correspondence, additions? Do we need an executive closed session meeting?
Sandra, you're muted.
Still muted.
Nope, no executive session.
Excellent. So then we need a motion to adjourn.
I would move that.
Second. I'll take that as a second. All in favor?
Aye.
Aye.
All right. Enjoy the rest of your evening.
All right.
All right. Good night, everyone.
Good night.
Bye-bye.